It's the 1st of May, 2020. This is the Rheum Now podcast. I'm Dr. Jack Cush, executive editor of rheumnow.com. This week, it's clinical trials regarding COVID-19. I reviewed them all this week, and there's been a lot of press releases, really from like the 20th to just yesterday, including the New England Journal. A lot of reports of concern to the rheumatologist because it concerns your drugs. And I'm going to review these in basically sort of a mini Grand Rounds weekly podcast. So if you're watching, you can actually see the screen, and I'm going to show you my slides. I think you'll find this informative. If not, you can listen along at home, and that'll work as well. So let's start out by talking about, there we go. Let's start at this. This week in clinical trials. I think the issue here is that our patients are supposedly immunosuppressed. Our patients are presumably taking immunosuppressants, but yet we are telling them, do not stop your prednisone, do not stop your DMARD, do not stop your biologic in this COVID era. If you get infected, then give me a call and we can discuss. The interesting thing is that we've noticed very few of our patients being infected, very few of them in the ICU, and even fewer of them dying from this coronavirus infection. So the question here is, do our diseases make our patients at risk? Does disease activity increase risk? Or is it the drugs that we use that can change risk, either help the patient or protect the patient? And there's actually some new information this past week that we should review. First, an update on the rheum-covid.org registry, the COVID rheumatology registries, one going on worldwide, one done by EULAR. Combined, we're over 1,000 patients, it looks like. You can go to the websites, and this is the data you'll get. These are patients with our diagnoses, most of whom have rheumatoid arthritis, next psoriatic arthritis or spondylitis, and next is lupus at about 12 or 8%. But these are patients who are infected with the coronavirus who've been enrolled in this registry. Around 65%, 2/3 of patients are female. In the worldwide registry, nearly 30% are elderly. In the UR registry, it's almost 50%. And it looks like 2/3 to 80% of patients are on DMARDs at the time they're enrolled. 22% are on hydroxychloroquine. When you look at biologic DMARD use, it's about 30 to 34% of patients enrolled are on a biologic. JAK's less common, steroids about 1/3 of patients. So far, we don't have any readout on this registry, but from the two registries and what's reported, about 2/3 of the EULAR COVID patients have been hospitalized, and in the COVID-Rheum registry, there's been a 9.2% of patients who have actually died from this infection. Again, this data needs to be verified. Yesterday, the New England Journal, Haberman et al., including Jose Scher, thank you, Jose, for sending this preprint to me, reported its experience at the NYU Langone Medical Center, accumulating patients in the month of basically March, and they accrued 86 patients with IMIDs, immune-mediated inflammatory diseases. That includes RA, PSA, psoriasis, AS, and IBD patients who were infected with the coronavirus or who were suspected as being infected. From this cohort, it looked like 16% of their patients were admitted to the hospital. Those who were admitted were more likely to be older, have hypertension, diabetes, and COPD when you compared them to the ambulatory patients. This rate of 16% is actually below, but yet on par with the New York City Health and Hospital Corporation rate of about 29%. So in New York City, the epicenter of coronavirus infections, where there's a lot of deaths, like, I don't think we have 80 deaths in Dallas. In New York, they're having 300 to 500 deaths a day. But anyway, the hospitalization rate in New York City is 29% currently. So this is low, meaning our patients aren't being hospitalized at the same rate. Certainly it's not more. If they were immunosuppressed, you'd think it might be more. But then when you looked at the therapies that were reported in this New England Journal article, you can see patients who are on steroids, hydroxychloroquine, and methotrexate were more likely to be hospitalized. So for instance, methotrexate, amongst the hospitalized patients, 43% were on methotrexate. Amongst those that were ambulatory with their corona infection, only 15% were on methotrexate. So does that mean those patients are more likely to be hospitalized? Well, let's look at what happens when you use a Jack inhibitor or biologic agent or a TNF inhibitor. It looks like in those cases, patients are more likely to be ambulatory. So those who are on a biologic or Jack, 50% of the hospitalized patients were on a biologic or Jack, but of the ambulatory patients, 76% were on a biologic or Jack. If you look at TNF inhibitors, nearly half the patients who are ambulatory were on a TNF inhibitor, whereas 21% of the people hospitalized were on a TNF inhibitor. I look at this and say those who are on more advanced therapies, maybe better controlled, were more likely to be managed in an outpatient ambulatory fashion. But the takeaway point of this article from Haberman et al. Was that baseline biologic use was not associated with worse coronavirus infections. There are a few articles in Annals of Rheumatic Disease and in Rheum looking at what happens when our patients have been affected by this. This particular report I'm showing you from Mathian in Annals of Rheumatic Disease looks at 17 patients with the coronavirus infection and what happened to them. So these 17 patients, they were all on hydroxychloroquine, and they've been on hydroxychloroquine for an average of 7.3 years. These people were pretty severe lupus patients. They had the antiphospholipid syndrome in 4, chronic kidney disease in 8, 12 on prednisone, 7 on immunosuppressants. Again, 14 were admitted to the hospital, 13 of the 17 had viral pneumonia, 11 respiratory failure, 5 cases of ARDS, and 3 renal failure. So when they looked at these patients, 8 of them, they had actually blood levels of hydroxychloroquine done and showed that they had plasma concentrations ranging from 254 to 2095, a mean of 648, suggesting they had good, healthy hydroxychloroquine levels, meaning they weren't undertreated. All the patients either had their immunosuppressant drug interrupted or stopped. 16 of the patients had no signs of lupus activity. And again, 14 were admitted, and at the period of follow-up they had, 36% had been discharged, 50% were still hospitalized, and 2 had died. The bottom line of this report was, yes, even lupus patients on hydroxychloroquine can get severe COVID infection, and 14% of them may, in fact, die. Another report from Italy was actually a survey. This is from Tomoleri and colleagues reporting on a survey they did of 172 patients with large vessel vasculitis. And they asked them, you know, have you been affected? How have you been affected? Have you actually got the infection? Turns out there was only 4 infections, 2 of whom were hospitalized, 2 of whom were treated as an outpatient, all did well and recovered. But what they did notice was, and it's unclear whether they had a higher rate, a lower rate. Again, it's a random sampling, but they did good. But they did note a fair amount of problems with the lockdown on delivery of care. So there were their infusions were affected, their care was affected, but no one relapsed during this short period of observation. 6 were unable to reach the infusion centers. 2 had to change to another subacute treatment. 2 went to another hospital. 2 were postponed. All in all, about 10% of patients actually had inconvenience and their care being affected by the COVID lockdown. An interesting report this week from Gold et al. In Medical MMWR from the CDC looked at COVID-infected patients in Georgia in April of 2020. The main purpose of this report was to say, hey, guess what? 1 in 4 hospitalized patients with coronavirus had no recognized risk factors for severe COVID, meaning they weren't obese, they weren't diabetic, they didn't have heart disease, lung disease, etc. But 26, 28, 30%. Overall, over 1 in 4 patients had no background comorbidity. But they also did list what was the number of people who had rheumatic or autoimmune conditions. And overall, it was low. It was 2.6% of the patients, very low in the 18 to 49 age group, 1%. Higher, 5% in the 50 to 64 group, and in the elderly over 65 was only 1.7. we're not very well represented amongst patients who are severely affected with the coronavirus. Another report came out this week in Arthritis Research and Therapy. Vincent et al. Did a meta-analysis of what happens when you stop biologics. This is important because all the guidelines are saying continue the hydroxychloroquine, maybe you should hold the biologic. Is there a consequence to that? I worry about that. What I think I'm going to show you and say here is that patients who are well controlled and are on therapy seem like they're doing fairly well in either avoiding or tolerating this infection. And I worry about patients who stop their biologics where they will go out of control, inflammation will rise, and their outcomes will be poor. Well, in this particular meta-analysis has nothing to do with COVID, by the way. It's just their RA and their SPA patients, 2,200 and 2,260 patients, all of whom were in remission. The RA patients, most of whom were RA, had a DAS-CRP of 1.6 to 2.3. Their BAS-DIs were less than 2. The infection rate in those who tapered and stopped compared to those who were usual were not different. They were basically non-inferior to each other. But in fact, those who taper had a lower infection rate, 1.7 per 100 patient years looking at serious infections, and 2.6 per 100 patient years for those who were on usual care and maintained their biologic. So this says that, you know, you probably can get away with stopping the biologic without increasing the infection rate, and that may be okay to stop these drugs for people who you suspect as having the coronavirus infection. So I want to remind you about the ACR guidelines. They were published this week. Ted Mickles from Omaha was the lead author on that. You can find that in Arthritis and Rheumatology. Again, the guidelines say do not stop therapies in people who you're seeing, that you should deliver normal care as you normally would. You should continue the ACE and ARBs for hypertension. You should not stop denosumab. You can extend it only as much as 8 months. There's a serious downside to that. But for those who are COVID exposed or undergoing testing, you should continue the sulfasalazine, hydroxychloroquine, nonsteroidals. Not sure what to do with the rest. And then if they are infected, you can continue the hydroxychloroquine, but stop sulfasalazine, methotrexate, leflunomide, immunosuppressants, JAKs, and biologics. You could continue the IL-6 inhibitor because it's not known what to do there. And for unclear reasons to me, they say stop nonsteroidals. It doesn't make any sense. There's no good reason to do that. But again, someone who's really sick with a positive infection, you're probably not going to use nonsteroidals anyway. But I want to point out some other points that we get from the studies. First off, the NIH guidelines on the COVID-19 infection say if you have mild, moderate, or severe disease, there is no current recommended therapy, either antiviral or immune modulatory for patients who have the COVID-19 infection. In this report, they do say there's no evidence favoring the use of hydroxychloroquine for prophylaxis or treatment of those who have the COVID-19 infection. If you're on steroids, you should probably continue it for a chronic disease. Don't use steroids to treat COVID. There's no evidence that it works. Use steroids to cover people in shock, if that happens, or use steroids for your protocol that you have locally in managing ARDS. Some centers do like that, some do not. So again, I want to show you some of the data on some of the drugs that we use and how they've been used in COVID, specifically chloroquine, hydroxychloroquine, IL-6, IL-1 inhibition, JAKs, and colchicine. So the VA trial, there was, first there was this trial out of Marseille of 26 patients. I'm not covering that. I talked about that past. It was a horribly flawed trial, and it basically said, looks like hydroxychloroquine with or without azithromycin may lower may lower viral titers or have more seroconversions. But it was a badly done study. This particular hydroxychloroquine VA trial is a preprint. It's not been peer reviewed yet. It's a retrospective study the VA experienced comparing those who are on hydroxychloroquine to those on hydroxychloroquine plus azithromycin to those with no hydroxychloroquine. Again, these are COVID patients on these drugs for whatever reason. This is just sort of an analysis of data. The primary endpoint was whether they died or whether they needed mechanical ventilation. And it turns out that they had worse outcomes, worse COVID outcomes in patients who are on hydroxychloroquine. So for instance, if you look at deaths alone, there's 28% of those on hydroxychloroquine died. 22% of those on hydroxychloroquine azithromycin died, versus those not on hydroxychloroquine, 11%. Again, these are people within the VA system. There was about the same ventilation across the board. Bottom line was a 2.6-fold higher risk of death with hydroxychloroquine. They summarize this by saying the findings from this retrospective study suggest caution when using hydroxychloroquine in COVID infections. And the last study on hydroxychloroquine is this COVID study from Brazil. It's an interim analysis of 81 patients. They were supposed to enroll 444 patients with severe coronavirus infection. They stopped at 81 when they noticed that there were 11 deaths. In this particular trial, patients were either given high-dose chloroquine, 600 milligrams BID for 10 days, or a lower dose of 900 milligrams on the first day and then 450 every day for 4 days. Of those in the hydroxychloroquine high-dose group, they tend to be older and tend to have 12% versus 0 in those on the usual dose, and then have more cardiovascular disease, 18% versus 0%. And these patients, the bottom line here is, will these drugs cause QT prolongation? They looked at that. In fact, it was higher in the high dose group, 19% versus 11% in the low dose group. But you know what? If you had QT prolongation, it was not associated with death or cardiovascular outcomes or torsades de pointe arrhythmias, which you might expect. It turns out that the people who died or more likely died were those who had pre-existing cardiovascular disease. And the people who died were also those who were older. So it may not be the cardiac effects of chloroquine. It may be that chloroquine in elderly people with cardiovascular disease may not actually be a good idea. They said skepticism towards the enthusiastic claims about chloroquine use should perhaps curb its exuberant use. So should you use these drugs? Again, there's a potential for their use because in vitro studies have shown that they may have antiviral activity through the mechanism by which they work. And the Marseille study said you might have more seroconversions. And you know what? The ACR and the NICE guidelines and the German guidelines say it's okay to continue hydroxychloroquine. The problem is that there are randomized controlled trials of antimalarials that failed in treating influenza or in preventing influenza, failed in treating dengue, chikungunya, and Ebola. That there have been studies showing no benefit in HIV, and there's one study showing a worsening of chikungunya virus infection, at least acutely. There's studies from China showing no differences in seroconversion rates if you're on hydroxychloroquine or not. The Brazil study said you had more deaths on chloroquine, and the VA study said they also had more deaths on hydroxychloroquine. The NIH guidelines are more judicious, saying there's no evidence for favoring their use at all. And recently, Health Canada and the FDA came out with a recommendation, a communique to the public saying, don't use this drug unless you're part of a clinical trial or in a hospital. But to use it outside of that would not be a good idea. Now, IL-6 inhibitors are in the news. We had a report this week about the 2 studies with IL-6 inhibitors. The idea is that you want to prevent, especially the cytokine storm, which can be a terminal event. Cytokine storm, macrophage activation syndrome, hemophagocytic lymphohistiocytosis, or the hemophagocytic syndrome, HLH, they're all the same thing. It's a cytokine storm induced by CD8 cells unable to lyse APCs and turn off an immune response. Instead, you have a sustained and amplified immune activation with a lot of cytokines being produced, typified and driven by gamma interferon. And that leads to the cytokine storm. High fevers, hypotension, altered mental status. You should suspect this when people who are not doing too bad develop pancytopenia, severe LFT elevations, and hyperferritin anemia. Other markers here are high LDH, high CD25, soluble CD25, high IL-6 levels, very high CRP, a dropping SED rate because they have lower fibrinogen levels. They can develop a coagulopathy with D-dimers. This has a high mortality when it happens. The treatment of the cytokine storm syndrome is so far IL-6 inhibitors, but there are trials with IL-1 inhibitors and emapalumab and other drugs that are usually used to treat macrophage activation. So let's talk about IL-6 inhibitors. As you know, there is a cardiac issue here, or is there? Up to 20% of patients on IL-6 inhibitors may develop a hyperlipidemia, but yet the observation has been so far that there's been no increase in MACE levels. I'll point to 2 different studies, one, a claims data analysis, and two, the Intract trial, tocilizumab against etanercept followed for 3 years, no increase in MACE events despite lipids going up. So that's a concern. But IL-6 inhibitors may very well work, and this is really based on a study that I've shown here from China, Zhu et al., 21 patients with severe hospitalized ventilator-assisted COVID-19 patients, and they all had high CRPs, high IL-6 levels, but when tocilizumab was given, guess what? They all rapidly improved clinically, their fever went away, their labs got better, and 19 out of 21 were discharged within 2 weeks. Very impressive. But now we have clinical trials going on. Regeneron and Sanofi issued a press release of one of the early results of their sarilumab study, 358 hospitalized patients with COVID. They were either given placebo or high dose sarilumab, 400 milligrams, or usual dose, 200 milligrams. And they compared the outcomes in a phase 2 trial of those who had severe disease, which is about 28%, or those with critical disease, about half the patients, critical being they were intubated in an ICU. Now, while many of these patients were discharged, 80%, the 10% did die in this study and 10% were hospitalized. The table I'm showing you on the right here shows that the primary endpoint was met with sarilumab. Placebo patients were only able to reduce their CRP in only 21% reduction with placebo, but with sarilumab, it had a 77 to 79% reduction, and that was the primary endpoint. But when you looked at other things like death or ventilator assistance, it's really different. So placebo patients, 55% of them died. If you were on sarilumab, 46% died if you had severe disease. But if you had critical disease, only 32% died or were on a ventilator, suggesting that only the critical patients are going to benefit from getting the high dose of sarilumab. So again, a preliminary result. It's got a lot of holes in the way it was written up. I'll just say it's encouraging data for sarilumab. More encouraging data came about this week with a report from France, where 129 patients with moderate to severe COVID-19 pneumonia were treated with standard of care plus or minus tocilizumab. The primary endpoint that they looked at was either death or ventilation at day 14. And the bottom line was no numbers, no data. They say that there were significantly fewer deaths and requirements for ventilator assistance in the tocilizumab group, suggesting that maybe, and so they're going to write that up. It might look good. We need to see that. But this is very preliminary data, and it's hard to say where this goes. I think this seems to work because really we're not treating coronavirus, we're treating the damage and preventing the damage incurred by the severe inflammation that may occur. IL-1 inhibitors are in clinical trials, both anakinra and canakinumab. There was a report also this week from the Stop Biologics in Annals of Rheumatic Disease. It's a case report, and it says a 70-year-old female with a 5-year history of cryopyrin-associated periodic syndrome, or CAPS, that was proven by genetic testing. She was being treated with canakinumab, 150 milligrams every 8 weeks, last given on March 15th. 10 days later, the patient develops a fever of 37.5, malaise, had a known exposure and a positive SARS-CoV-2 test. White count was 4.3. Sed rate was, CRP was high at 9 milligrams per deciliter. 12 days later, the patient had her symptoms resolved and the SARS-CoV test was now negative, suggesting that our patients with inflammatory disorder on a biologic may have a more benign course and certainly not a severe outcome. This is encouraging, but it's an N of 1. It's hard to say what it means. Lastly, an interesting report about baricitinib. You know, baricitinib may work because it's been shown to inhibit AAK1 and G-associated kinases, two important regulators of endocytosis, and endocytosis is the means by which the coronavirus is going to bind to the ACE2 receptors and via endocytosis gain entry into the cell where it's going to do its damage. Moreover, a JAK inhibitor has the advantage of decreasing cellular activation and cytokine signaling and overall decrease in inflammation. So we have one trial that's out there, and that trial is called It's authored by Cantini, also came out this week. They treated 12 patients, 12 consecutive patients who were hospitalized with a COVID, and they were COVID positive, hospitalized with X-ray proven pneumonia. 12 consecutive patients were treated with Baricitinib 4 milligrams a day, plus antiviral therapy with ritonavir, lopinavir for 2 weeks. And then the outcomes were measured at 2 weeks. They have a control group where the 12 patients that were treated before these 12 Baricitinib patients were enrolled. And those people were given the same antiviral therapy, but they were getting hydroxychloroquine 400 milligrams for 2 weeks. Again, there was really no SAEs in this trial. There was one patient who had really high LFTs in the 250 to 600 to 300 range, presumed to be due to antiviral therapy. So what happened when you got hydroxychloroquine or Baricitinib on a background of antiviral therapy? Guess what? The hydroxychloroquine control group did not do well. They had no significant changes in their clinical status or their labs, but the Baricitinib group had significant improvement in CRP levels, in lymphopenia improved. ICU admissions were 0 in the Baricitinib group and 4 in the control group. Discharges were higher in the Baricitinib group, 58% versus 8% in those in the control or hydroxychloroquine group. Encouraging first step data that should drive the use of this in future trials. Colchicine, as you know, is going into a clinical trial that was started by the Montreal Heart Institute, UCSF, and NYU. They're going to enroll 600 patients. The idea here is give this to early patients, treat them with 0.5 milligrams BID for 3 days and then QD for 27 days. You had to have the coronavirus plus you had to, here we go, you had to have a high risk factor. That's age, diabetes, lung disease, heart disease, CAD, fever, dyspnea, pancytopenia, any risk factor. They want to see at that point whether you may have a better outcome. The primary endpoint is going to be death or hospitalization at the end of the month. They expect the results of this to be done by September of 2020. You know, there have been reports in the literature we covered this week about B cells maybe being active, that patients with A-gamma globulinemia seem to do well. They have no B cells and no immunoglobulin, they seem to do well. Whereas CVID patients with sort of dysfunctional B cells, they didn't do well. They had more severe courses. What about TNF inhibitors? There's a report in Lancet from Mark Feldman and Tiny Maney and colleagues suggesting we should be studying TNF inhibitors in patients with the COVID infection. Look for that report in Lancet. And then lastly, Amgen announced yesterday that they're going to be doing studies of apremilast, the PDE4 inhibitor, in patients with COVID infection. As you know, it's approved for use in psoriasis, psoriatic arthritis, Behçet's. How this works, it doesn't work very well. It's kind of a mild drug, very safe, works in some people really well, doesn't work in a lot of patients. But, you know, how it works mechanistically, you know, it decreases intracellular CAMP, cyclic AMP, but does it actually affect cytokine production? I think it actually has a lot of effects on neutrophils and chemotaxis, and that may be one reason why it may work, especially if used early when the innate immune response is kicking in. We'll have to wait and see where that goes. Anyway, I think that our patients are at low risk, and I think they're at low risk because we have them well controlled. If you look at this graphic by Randy Cron and Wynn Chatham from UAB, it suggests that by bolstering their immune response in those with autoimmune disease and controlling their disease, and by doing replacement in those who have immunodeficiencies, you allow your patients to better manage infection. So, and maybe they're primed to better manage infection. Maybe that's why we're seeing good outcomes. This is my hypothesis. We need more data. Hopefully, our big Rheum registry of COVID patients will tell us more in the future. Anyway, that's it for this week on the Rheum Now podcast. Go to the website. You can watch this, find some of the links that I have in here, and tune in next week for more information from Rheum Now. Take care. Have a good week.